Hi, it's Laurie Sullivan here. I'm just wanting to present a case of a Phakic DMEK, and again it's just demonstrating the use of preloaded tissue. This lovely family doctor has Fuchs dystrophy and is developing corneal failure in both eyes. She's Phakic and, as you'll see, has minimal lens haze. So I've marked the cornea with a 7.5mm fine, and I'm just starting to score the Descemet's membrane here, and you'll just see that as I go around, it comes off quite easily, and it's quite loose and quite a thickened Descemet's. So I'm deciding to score towards the area that I've already scored rather than pulling around. The reason for that is if you have quite loose Descemet's, you have a tendency for it to sometimes tear out towards the periphery when you're scoring, and I really don't want to have a very large strip of Descemet's membrane. So I'm just changing position there and scoring towards the already scored areas. And just starting to gently strip away now. The idea is to try to do this without leaving any tags. I find that almost always I do leave a couple of tags that need to be addressed later. So this is done under viscoelastic, under cohesive viscoelastic. You can see there's the Descemet's membrane, it's quite thickened, and now I'm just using irrigation aspiration. There's already some vision blue there, and you can just see that exiting. I'm just going to refresh the vision blue in the AC now and look for tags of peripheral loose bits. There's some just next to the incision there. There's a tag next to the incision there that I'm just going to get with the aspiration cannula, and that's on high vacuum. So I just have that tag there that I'm trying to free. It's easier if I pressurise the AC and it comes away and aspirated. There's another small one distal, and I get that as well. So here's the preloaded DMEK in its carrier, with the injector in its carrier as it comes delivered. I've at the start of the case, I've restained the graft by injecting vision blue into the cartridge. It's not particularly well stained, and you often have to restain it a couple of times to get a nice visible graft. And here I'm just redoing some injection of the vision blue just to show you can inject that through the cap at the end of the cartridge quite easily. And I'm going to get some better staining now. Just removing the end caps from the injector under BSS and attaching a fluid-filled syringe and tubing, and just gently aspirating out the fluid, diluting out the vision blue, and bringing the graft into the business end of the injector. Now I've got to take the cap off the rear end of the injector and attach another fluid-filled 3mm BSS syringe to the proximal end, and then removing the tubing from the distal end and just looking at the graft at its conformation there before trying to advance it a little bit. That went rather quickly, and it sometimes does. You have to be careful with pushing on the plunger. Just getting ready to inject it. And the AC is quite depressurised in this situation. Pressurised AC, you may eject the graft as you inject it. So just trying to do this gently, but sometimes it's a bit faster than you'd like, as in this case. Slowly withdrawing the injector so the graft doesn't follow it, and just tapping it around so it's at perpendicular to the main wound, and popping a suture in. And you can see here the S is reversed, so that graft is at the moment sitting upside down. So we'll need to flip that. Let's do that with some jets of BSS in the AC. Bury the suture whilst the eye is pressurised. And just tapping to really get an idea of the conformation, and there we go, flipping the graft there with the jet of fluid. There's a little bubble in there which is of no consequence. Depressurising, holding and tapping, just trying to get it to unfold in the right way. Nudging it across, depressurising again. Because I think the graft is the right way up and it's going to unfold nicely. Even though that S is backwards, it's folded over. Now we see as the graft unfolds, that the S is the right way around. And it's nearly in perfect position there, so I probably should stop doing things now and inject some air or SF6. I initially use an air bubble just as a primary bubble, just to make sure we have the correct position, and then I'll aspirate that air and replace it with SF6. Just insinuating the cannula under the edge of the graft there, on top of the iris, and just slowly injecting that air bubble. And just looking at the positioning of the graft now, there's the S stamp in close-up. You can see nice and peripheral and not too heavily inked. Heavy inking of the S stamp can cause some endothelial toxicity, I believe, and you can get some focal edema around it sometimes. But that looks pretty good. So I'm just stroking here to extrude any fluid from the interface if I can. And that looks good. So now I'll aspirate some of that air bubble after probably deepening the AC a bit with BSS, and replace it then with the SF6 gas. Just aspirating a little bit of air and injecting some BSS. As the chamber deepens, the bubble appears to decrease in diameter. Again, aspirating some air and injecting some BSS. Each time I go in with that cannula, I'm very careful to make sure I'm getting under the edge of the DMEK graft. Again, aspirating and just injecting some more BSS. The graft is still sitting nicely. And now SF6. Hydrating the wounds with cefazolin solution, checking pressure each time. And just one last re-injection of SF6, checking the pressure with my finger. And we're essentially done there. I always like to leave some viscoelastic on the ocular surface at the end of the case. It usually means the patient's much more comfortable in the early post-operative period. And here's the day one view. The stamp's well seen there, the graft's in good position, and the edema is starting to clear from above. Thanks very much for watching.